environmental risk factors, and some of those include smoking, toxins such as metals, solvents, radiation, and electromagnetic fields, warfare. So we do see a little bit of a higher incidence of ALS in veterans and also athletes. So exercise is on the list. Some others include pesticides, viruses, or this chemical called BMAA. Now, as far as the genetic factors go, most of the time, the genetic factors involved in ALS development are probably an interaction of multiple genes in your body. So changes in several different genes that mix together with your environmental factors and create this cocktail that causes disease. And so unfortunately, majority of the time, we don't have a magical test to be able to pinpoint every single little thing that went wrong that led to the condition. So a small portion of the time, we can actually identify a single genetic cause for ALS, and that's what I'm going to be focusing on with today's presentation. But in general, ALS typically can be categorized into two different categories, sporadic and familial ALS. So with sporadic ALS, we refer to that as SALS. And this is what we see the majority of the time. So sporadic ALS is referring to a patient that has the condition, but has no one known in the family with ALS. So about 90% of ALS that we see is sporadic. Familial ALS is when somebody has ALS, but also has a relative that's affected with the condition. So that might be a parent or a sibling or an aunt or an uncle. And familial ALS, which we call FALS, makes up around 10% of all ALS. So it's the minority. There's a third term that is occasionally used, and I'll elaborate more on this later, but that's DALS. And that is referring to when somebody has ALS. They don't have a known family history of ALS, but they may have relatives with dementia. And I'll talk more about why that's relevant. So like I said, sometimes we can find a single genetic cause that is responsible for ALS. So this is one gene that is defective and is responsible for someone's disease development. So we can find this in both sporadic and familial ALS, which means that anybody that has a diagnosis or a strong suspicion of ALS is eligible for genetic testing, regardless of what their family history looks like. So with sporadic ALS, we can find a single genetic cause in up to 15% of cases. With familial ALS, that's much higher. So we can find a genetic cause in around 70% of cases. So before I go any further into the genetics of ALS, I think it first would be best to do a quick genetics crash course, because it may have been a while for some people since you've been exposed to genetics, or maybe you haven't been exposed at all. So you might know that our genes are essentially like the instruction manuals for our body. So a gene is basically made up of a long strand of letters, which is our DNA. And those letters provide instructions for how our body should be making proteins. Our proteins are necessary for every single function in our body. So our proteins are necessary to keep us healthy, necessary for our development. So it's very important that our genetic instructions are correct and making functional proteins so that we can stay healthy from disease and develop normally. So on the left, what you're seeing in that little picture, that's essentially what our DNA looks like. And if you zoom in really closely on a gene, it looks like this little strand of letters here. So it's just a bunch of A's, C's, G's, and T's that are written out just like this. And that's providing instructions for how proteins should be made in your body. It's important to know that we all have the same genes. So every single one of us on this call has the same genes. It's just dependent of what exactly our instructions look like. So as long as our instructions are spelled correctly, our proteins should be made normally and should function appropriately to keep us healthy from disease. If we are born with mistakes in our instructions, that can confuse your body, and the protein product that's supposed to be made is no longer functional. And that can lead to lots of different diseases, one of them being ALS. So I call them misspellings in our genes or our instructions. And that is what leads to dysfunctional proteins and ultimately disease. The fancy word for these misspellings is a mutation, and it can be as simple as a single letter being off. So as you can see in the top strand, that is making a normal protein. If you change a single T and make it an A instead, almost like a typo, that can completely disrupt the protein product and lead to disease. So we all have genes that are supposed to be making proteins that are supposed to be keeping us healthy from motor neuron disease. So they're supposed to be protecting our motor neurons. However, if you are born with a mistake, a spelling mistake in one of these genes, which again we call a mutation, that can put you at an increased risk to develop ALS in your lifetime. So we now know of around 40 different genes that have been associated with ALS. So again, these are genes that if you have a mistake in one of them can put you at risk to develop ALS in your lifetime. So these are the 4 most common genes that are seen in genetic ALS. C9orf72, which I call C9 for short because it's a lot to say. SOD1 is the second most common. Then we see FUS, TARDBP, and then several others as well. As I said, there are around 40 now that we know to cause the disease. So as you can see, these genes are found in both familial and sporadic ALS. They're just found at a much greater ratio in familial ALS than we're seeing in sporadic. Something that is important to know is that ALS actually has been long recognized to form this sort of neurodegenerative continuum with a condition that's called frontotemporal dementia, or FTD for short. FTD is a progressive disorder that affects behavior and language. So it's a very specific type of dementia, different from Alzheimer's dementia, where a lot of times patients might start having abnormal behaviors. They might be impulsive or inappropriate, or even doing strange things like gambling or just bizarre behaviors that they weren't doing before can be signs of the condition, but it can also affect language and how you're able to speak. It's been reported that up to 50% of individuals that have ALS develop cognitive impairment that's associated with frontotemporal dementia. And on the other hand, up to 30% of individuals with frontotemporal dementia might develop symptoms of motor neuron disease. So essentially, ALS and FTD are both caused by the same underlying pathology, which is this abnormal buildup of a protein called TDP43. And so that's why they're sort of on this continuum of disease where we can see maybe someone just has ALS, maybe they have ALS and FTD. And the reason I bring this up is because there are a couple of genes that can cause ALS in some people, FTD in other people, or both conditions simultaneously. And sometimes when you look at a family history, you might see ALS in one individual, dementia in another individual. And so that's why I mentioned this term DALS, which is referring to someone that has ALS. They might not necessarily have a family history of ALS, but they could have a family history of dementia, specifically frontotemporal. That's a flag that maybe there's a hereditary connection there. So back to this C9orf72 gene, like I said, I call it C9 for short. This is the most common known genetic cause of ALS. So most commonly seen in sporadic and familial disease. It's responsible for about 7% of sporadic ALS and 40% of familial ALS. So the specific spelling mistake or mutation that occurs in this gene is referred to as a hexanucleotide repeat expansion. So back to thinking of a gene as a long strand of letters, essentially what happens with this gene is there are 6 letters, G, 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 C, C, that repeat themselves over and over again in our gene. When somebody has too many of those repeats, so specifically more than 30, it causes disease or ALS. Now, this gene is an example of one that can cause ALS in some people, frontotemporal dementia in other people, or both conditions simultaneously. And it is not the only example of a gene that can do that. So some others include that TARDBP gene, VCP, FUS, and a couple of others. So as we talked about, there are now several genes that are known to 40 of them. And sometimes, depending on what gene might be mutated or involved in someone's disease development, that can affect how they might be progressing or how early their symptoms might occur. And even more specific than that, sometimes even the exact spelling mistake in that gene can determine whether someone is rapidly progressing or more slowly progressing, or what their course might look like overall. So for example, the SOD1 gene, there are some mutations in that gene that might have a more slowly progressive course, or maybe even people could have that mutation and never develop ALS in their lifetime, whereas there are others that are a more aggressive course. And it's the same gene, it's just a matter of what spelling mistake you have that could be altering the way that your disease is presenting. I mentioned this, but inheriting a mutation in a gene that causes ALS does not guarantee someone will get the disease in their lifetime. So again, this depends on what gene it could be or what mutation in that gene. But that's very important to know that, you know, not everyone that has something wrong with one of these genes will develop ALS. So I'll talk about this later, but predictive genetic testing is something that I see a lot, where unaffected relatives want to know if they're going to develop ALS by undergoing genetic testing. And this is an important consideration, that if they test positive for something, they're not necessarily going to develop ALS. It just depends. We also cannot tell if someone would develop ALS or frontotemporal dementia or both conditions simultaneously, if it's in one of those genes that we know is capable of causing those conditions. So this can make it very tricky and complex to do predictive testing, and something, one of the reasons we encourage patients to undergo genetic counseling so they can understand everything they're getting into. Something interesting about that C9 gene is that, yes, it's the most common genetic cause of ALS across the board. It's seen in all populations, but this is a predominantly European mutation. So it originated in Europe. It's pretty much predominantly stayed within the European population. So it's important that patients are offered genetic testing of more genes than just that C9 gene, even though it's the most common, because we want to make sure that minority populations have equal opportunity of obtaining a genetic diagnosis for their disease as well. So how are these genetic forms of ALS passed through families? So we have 2 copies of every single gene in our body, because you get a copy from your mom and a copy from your dad. So this SOD1 gene, it's a gene that we all have, and we all have 2 copies of it. Most genetic causes of ALS, including SOD1, are caused when there's a mutation in just one of your copies. So this little X here is showing that there's something wrong with just one of the copies, but the other one is fine. Now we call this a dominant disease because this bad copy dominates over the good one and puts you at risk for disease. So all it takes is one mutation, one copy to be mutated. Now, anytime someone goes to have a child and they have this type of condition, it's a 50-50 whether they're going to pass on this bad copy of the gene or this good copy of the gene. So when we start to think about what risks looks like for relatives when someone has a known genetic form of ALS in the family, anyone that person shares half of their DNA with, that means their children, their full siblings, and their parents, those people would all have a 50% chance to also have a genetic mutation in that gene. And again, that might not guarantee ALS in their lifetime, but that is something where genetic testing can sometimes open this window for other people in the family to learn more about their risk if there's interest. So in general, when a patient comes to see me, again, most of the time ALS is sporadic. So we're not seeing a family history of the disease. So before they undergo genetic testing, I can tell them that the risk for their first degree relatives, that means parents, siblings, and children, the people you share half of your DNA with, is expected to be between 1% and 3% to develop ALS in their lifetime, which is relatively low. If that patient decides to undergo genetic testing and they have negative genetic testing, then we can say the risk for those relatives is even lower than that. It's expected to be less than 1%. If that patient undergoes genetic testing and they are found to be positive for something, then the risk for their relatives would be up to 50% because it's most likely a mutation in a dominant gene where it's a 50-50 for all of those relatives. Now for familial ALS, if we're already seeing a family history of multiple people with the disease, we can tell, regardless of genetic testing, that risk for other relatives, such as parents, siblings, and children, is up to 50%. We know there's already a capability here of this being hereditary. Familial testing is a little bit tricky because even when negative, there technically still could be an increased risk for those relatives, because if you remember from one of the first slides, we only find a genetic cause for familial ALS in up to 70% of cases. So that 30% might be genes we haven't discovered yet. So we can't say that there's no risk for relatives, even when someone has negative genetic testing when they have familial ALS. So why would someone consider genetic testing for ALS? So sometimes it can help us confirm a diagnosis. So if it's questionable, maybe someone has a few signs of ALS, but it's not a slam dunk by clinical examination. And ALS in general is a difficult diagnosis to make clinically. If we do genetic testing and someone is positive for a mutation in SOD1 and they're having these symptoms of ALS, that would help us to say, okay, yes, this is likely what's going on. Sometimes testing can provide us with prognostic information. So as I said, some genetic forms of ALS may be more rapidly progressive or slowly progressive. Some may be more likely to present with dementia. So maybe now we need to send someone for a cognitive evaluation to make sure we're on the lookout for those things and intervening if we can. A big one that patients mention when they consider genetic testing is information for their relatives. So knowing what risk might look like for their children or their siblings, and also to assist with family planning. So some people might want to know if they're thinking about having children, what that would look like and what are their options for reproducing. A big one is to try to figure out eligibility for current or future clinical trials. So we are heading in the direction of trying to treat the underlying genetic problem of ALS instead of just trying to slow progression with medications that are used today. So the thought is if we can get to the underlying root and attack that, maybe we can really slow progression or even cure the disease or prevent the disease in someone that has a mutation but hasn't developed symptoms yet. Some patients may want to do it just to contribute to research. So we are still very much learning about the genetics of ALS, and patients sometimes feel empowered that they're a part of that story. And ultimately answers and closure. As we know, this is a tough disease. And sometimes people just want answers as to where this came from. As I said in the beginning, we have theories about environmental exposures and what could be involved here, but as humans, sometimes we just need closure and reasons for why things are happening. And sometimes that's enough for patients to want to do genetic testing. It's important to know that ultimately genetic testing is optional. This is not mandatory for anyone. It's something that I offer to everyone that comes through our ALS clinic, but there are all sorts of reasons why people may choose or choose not to undergo genetic testing, and we always want to respect that. There's a couple different types of genetic testing. So the first and most common is called diagnostic testing. So that means that someone is already affected, but now we're going to do genetic testing to see if we can figure out why they developed this condition. It's important to know that when someone has ALS, if we do genetic testing and they're negative, that does not take away their diagnosis. So we're just trying to figure out why did this happen most of the time. So testing should be offered to all patients with ALS. It is important that patients undergo genetic counseling. So things that we might talk about are a lot of what we've discussed today. So education on the genetics of ALS, what a positive result might mean for that patient. So, could they be at risk for frontotemporal dementia, or, what types of information are we going to be learning here? And what are we going to be learning about family members? Maybe people don't want to know if others in their family could be at risk for this, or maybe those relatives don't want to know. And sometimes there are multiple people involved in these conversations about whether or not testing should be done. There are multiple labs that now do genetic testing for ALS, and a couple of them offer it for free. So pretty much anyone with a diagnosis of ALS can get free genetic testing, and it's comprehensive. It looks at multiple genes, usually around 30 or so, that are linked to ALS. And genetic testing can be done in person. So I see patients that come through our ALS clinic, but also can see patients via video visits. So sample collection can be done for genetic testing through blood draws, but we can also do saliva samples or cheek swabs. So those things can all be done in person, but if someone wants to do the video option, I can have cheek swabs or saliva kits sent straight to their home. So people do not necessarily need to come in for genetic testing. The other type of genetic testing that we can see in the ALS setting is called predictive testing. So that is when an unaffected individual has a family history of ALS and they want to undergo genetic testing to better understand their own risk to develop the disease. So this is most informative if we have already identified a genetic mutation that causes ALS in the family. So for example, if a patient comes in and her father has ALS, we first want to figure out if there's a mutation that explains his ALS, because then it's much easier to test the daughter and say, yes or no, do you have that mutation? If we don't have that information, technically patients can still do predictive testing. It just makes it harder to interpret. So for example, if that same daughter comes in, we don't know if her father ever had genetic testing, but we do testing on her and she's negative. I don't know if she's negative because her father had a mutation that he did not pass on to her, and then she would truly be negative at an extremely low risk for ALS. Or is she negative because there was not a mutation in her father in the first place, or maybe a gene we haven't discovered yet is responsible for his ALS. So it may not be a true negative for that patient. So it can get us closer to risk assessments. I mean, a negative result is promising regardless, but there's always that possibility that maybe a gene we haven't discovered yet is responsible for what we're seeing in the family. And it can be a little tricky in that way. As I mentioned before, a positive test result does not always guarantee disease development. And another thing is sometimes patients will, with ALS, will see me, will do genetic testing, and they're negative. Then their relatives will wonder if they should undergo genetic testing. And the answer is no. So if we tested someone that's affected and we did not find a mutation, there's no need for their unaffected relatives to go testing for something because they can't inherit something that their affected relative never had. So when an affected person is negative, the other relatives do not need to test. Something that's important to think about really for predictive testing, but all genetic testing, is something called GINA, which stands for the Genetic Information Non-Discrimination Act. And that is an act that's in place that says health insurance companies and employers cannot discriminate against someone for a genetic test result. However, GINA does not protect people from discrimination from life insurance, long-term care insurance, military, or disability. So most of the time, if people already have these plans in place, it's unlikely that a company would then go back and say, have you had any recent genetic testing? Also, if someone is already affected by ALS, these companies are much less likely to care about what the genetic test result says because they care more about the symptoms that they're seeing. But for people undergoing predictive testing, this can be an issue because if someone is unaffected, they do testing, they test positive for a mutation in SOD1. Now we know they have this increased risk to develop ALS. And if they go to try to get life insurance can technically ask, have you had genetic testing, and maybe deny them a policy or make adjustments to their policy because of that, because they know they're at this risk to develop this neurodegenerative disease. So these are all conversations that I have with my patients. And again, highlighting the importance of genetic counseling so that patients and unaffected relatives know what they're getting into. So I talked a little bit before about how patients might want this information for their relatives, but also for understanding reproductive risk and to help with family planning. So patients that are thinking about expanding their family might wish to learn about their risk for ALS if they have a family history of it. So there are multiple reproductive options for those that have a known ALS mutation in their family, whether it's in them or they have a relative that has a known mutation. One of the options is called pre-implantation genetic diagnosis, or PGD. That is a procedure that is done in conjunction with in vitro fertilization, or IVF, to reduce the risk of passing on a genetic mutation. So it's essentially genetic testing of embryos to selectively make sure that the condition is not passed on. Patients can do this if they know their own status. So let's say there's an unaffected individual with an SOD1 mutation that does not want to pass this on to a child. PGD can be done, testing an embryo to ensure that doesn't happen. But also someone does not need to know their own status. So let's say this patient's father had an SOD1 mutation and she does not want to know herself if she inherited it, but she also wants to make sure that her future children are not affected. So you can do PGD through what's called non-disclosure PGD, where essentially they would still test your embryos, they would still implant the ones that are unaffected, but they're not telling you whether or not any were affected in the first place. They're not telling you your own status that way. So really the summary is that there are prenatal and reproductive genetic counselors that can help patients talk through these things when there's a known genetic mutation in the family. So genetic counseling, why is it important? A few of these I've already highlighted on, but my job as a genetic counselor is to help patients understand the medical, familial, and psychological implications of their genetic condition. So, we talk about what a genetic test result might mean for their own health, what it could mean for their relatives, what it could do to them psychologically. So a lot of times we walk through scenarios and determine, is this information that you really want or can take on at this time? Pre-test counseling helps patients understand the complexities of the genetics of ALS before they get a result. And having that background information makes it much easier to have a discussion once the results come back, and for the patient to be able to grasp that information and make informative decisions with it. I also, help patients communicate risk with their relatives. So this can be difficult to do, to explain genetic information to other people, or sometimes is putting patients in a vulnerable position where maybe they need a little bit of help doing that. So sometimes even as simple as I'll write a letter that they can give to their relatives if they want to, that explains what we found, explains what the risk looks like for that relative and how they could potentially go about genetic testing if they wanted to. So one of the things that I mentioned, one of the reasons people might consider genetic testing for ALS is eligibility for clinical trials. And a big thing that we're working on is genetic therapies. So as I said, these are therapies that are trying to go after the root of the problem, the genetic mutation, instead of just trying to slow progression or treat the symptoms that we're seeing. So this is essentially a therapy that is in place for patients that have SOD1 ALS. So their SOD1 gene is mutated. This therapy is called antisense oligonucleotide therapy, or ASO. Essentially what happens is our DNA, our instructions, like I said, are converted into proteins. And in between DNA and protein, there is this second step or the second product in between called mRNA. And so essentially ASOs go and find this mRNA before it can be turned into the final protein product, and they get rid of it. They take it down. So the issue with SOD1 ALS is that when patients have mutations in this gene, it's creating this toxic effect. Their SOD1 protein is essentially toxic to their cells and to their motor neurons. And so if we can go in and get rid of this toxic SOD1 and prevent it from having this downstream effect on cells, then that might slow progression or potentially cure the disease, depending on when this is initiated. So there's a drug called tofersen, and it is available for patients that have SOD1 ALS. The drug name when it was through trial is BIIB067. So this is an example of an antisense oligonucleotide therapy that targets SOD1. It's administered to patients through a lumbar puncture. And there is currently an early access program in place to help patients with SOD1 get access to this. So this did go through clinical trial through a study called the Valor study. While the overall outcome is that it did not meet the endpoints that they were looking for. So they were looking for improvement in the ALS functional rating scale. They did see some minor improvements in overall slowing of progression. So because of that, because there was slowing of progression, they also found that there was a reduction of that SOD1 toxic protein. They found reduction of something called neurofilament, which is a sign of neurodegenerative disease in the body. And again, some positive clinical outcomes. They did go ahead and make this an available drug. So this is something anyone with SOD1 ALS is eligible for, and there are a few participating sites that actually do this therapy. We are not one of them, but we can help you connect with one of those sites. So that is everything that I wanted to share. Thank you so much for having me. I work for the Medical University of South Carolina, so I can see patients in my state in South Carolina, but there are neurology genetic counselors all over the place. So if you or someone you know is interested in genetic counseling to learn more, whether they're affected with ALS or have a family history of ALS, I'm happy to help connect or point you in the right direction. So my contact info is here. You're welcome to contact me via email or phone at any time, and I'm happy to take any questions.
All right, Maysen, let's see. Anthony has a question, and it says, with sporadic ALS, what specific viruses have been known to predispose a patient to ALS, and has COVID-19 been linked as well?
So that is a wonderful question, and I'll be honest, I don't know. I'm I'm sure there are studies actively looking at COVID-19, but that I'm not sure. What I would guess would be more so of viruses that attack the central nervous system, something like a meningitis or encephalitis, but I don't know more specifics beyond that. I apologize.
Okay. Are there any other questions? Right now, there have not been any other typed. If you have questions for Maysen, you can go down. Mine's on the bottom of my screen where it says Q&A, and we will be glad to, well, Maysen will be glad to answer any of those questions. In case someone's typing as we speak, Maysen, I want to thank you for your time. Your bio, I first thought was, where is she getting time to do anything with everything that you're doing? So it really means a lot that you took your time this afternoon to come and speak. And it was a really informative presentation, and I really, really appreciate it. So
good. Well, I'm so happy that you found it informative, and very happy that I could be here. It's truly my pleasure.
So I don't know, there aren't any questions that have been typed in, but I wanted to know, and this is a sort of a roundabout question, does the pre-genetic counseling, let me back it up. I know someone who was tested for, not for ALS, but for something totally different. Mm-hmm. And prior to the test, the lab that tested them required them to have genetic counseling, but it was done through the lab. Is that the norm, or is that just an oddity for this one thing, or?
Yeah, it would depend on the condition. That's not the norm, but for some common conditions, that's starting to become more of an accessible option. So sometimes that's usually a option in place when there's not a genetic counselor available at that site. So maybe it's something like someone might be seeing an oncologist that doesn't really feel comfortable doing the pre-test counseling themselves. So they might order the genetic testing, but then ultimately have a genetic counselor with the lab do the pre-test process. And again, it just depends on the condition, but that is available for some things.
Okay, thank you. So we do have another question. Tess says, is ALS predominantly a European descendant derived illness? Caucasians mostly being affected?
So the incidence is highest in Caucasians, but it does affect all populations. So we see it all over the board. And again, most commonly in Europeans, and some of that could be, reduced ascertainment of cases in minority populations. Maybe those people are less likely to go receive care. But for now, what we know, the incidence is highest in Caucasians, but it's not drastic.
Okay. So this other person said they've been trying to get the tofersen for a year. How did they go about finding it? The drug is provided and sponsored through Biogen, and Biogen has specific medical liaisons that can help get you access to that. What's tricky with tofersen is it's a lengthy application process that a provider needs to fill out that basically says the patient is a candidate for this, and then finding a site that will actually do the lumbar puncture essentially. But if you have not connected with the Biogen team, I'm happy to help connect you and see if they might be able to find a way for you to get access to that. If there's not a provider at your own site that can help you, they should be able to find someone that can. Okay, thank you. So what is the percentage breakdown between sporadic and familial ALS?
So familial ALS is about 10% of all ALS, sporadic is 90%. So we see sporadic much, much more. We can find a genetic cause of sporadic ALS in about 15% of cases, and we can find a genetic cause of familial ALS in about 70% of cases.
So they have another question, and how expensive is the genetic testing?
So a few labs offer it for free. So most of the time you should be paying nothing. Essentially, the way that it's free is this testing is sponsored by pharmaceutical companies like Biogen that are trying to learn more about the genetics of ALS. So they essentially pay for it. It doesn't even go through your insurance and it's free. So there are a couple labs that do that. And if you don't want to go that route, usually there are very reasonable options with insurance companies. Patients with Medicare usually don't have any out-of-pocket costs if you go through Medicare. Through commercial insurance, I usually have success getting it covered. The absolute highest cost testing would be $250, and that's if you just paid cash essentially and didn't go through insurance. But really, with all of the other options, that shouldn't be necessary.
So I'm going to add on to that, jump on to the end of that question. So if someone is a patient with ALS, I'm assuming they could get this testing, start the ball rolling through their neurologist. What if they are a family member and possibly the patient has passed away, or there's a gap between when the family was going to a neurologist?
Yeah, so they would want to see a genetic counselor for that. So I have patients that are unaffected, and that's the exact story. They had a family history of ALS, that person's deceased, and they want to know what their risk might look like. They would meet with a genetic counselor. So there's a website called Find a Genetic Counselor. So if you just Google Find a Genetic Counselor, it's through NSGC, which is our national society, that can point you to one to potentially reach out to directly, or by asking your primary care physician to refer to a genetic counselor. Usually that can help patients get in the right place. I'm also happy to be a resource to help connect any patients that are looking for a genetic counselor.
Thank you. So the person who had the question about the tofersen wanted to know, is there a cost to that medicine?
That is a really good question. I don't think so, because it's technically still like part of a trial. So it's in this early access program, which is technically still clinical trials. So it's not an FDA approved medication. So I don't think that there is.
Okay.
But I don't know that with absolute positivity.
Okay. And this person said NIH All of Us project offers free genetic testing and counseling. Thank you. Thank you for that. All right. Any other questions or anything before we? And I wanted to tell you, Maysen, this was recorded and I will take the blame. I didn't hit the button until like the second slide. So
that's okay. No problem.
All right. I don't think we have any other questions right now. So Maysen, once again, thank you so much for your time. It is truly, truly appreciated. And I took some notes and stuff, and I know there's some other folks. Oh, can we get the slides for your presentation? Thank you, Tess.
Sure, that's no problem. I can send them to you, Jerry.
Okay, good deal. And then I will send them out to the team and the different care service coordinators, and they can send them out. If you have any questions or anything, any of the folks they can reach me at Jerry, which is JERI .Prosser, PROS as in Sam, S as in Sam, ER at ALS.org. All right. Thank you so much, Maysen. I am going to end the conversation now, and you have a good day and stay safe.
Thank you. You as well. Have a good one.
All right. Bye, everybody.
Bye.
Thank you so much for attending.